Hi, everybody. Welcome to our June Neonatal GaPQC Optimizing Newborn Nutrition webinar. We have a couple of updates and then we'll get right into our presentation for today. I just want to remind everybody that we do have new micro lessons on Train. The easiest way to access those micro lessons are going to the Train website, so train.org/Georgia. You have to make an account. Once you do have an account and you log on, if you search GaPQC, all of the micro lessons that are up right now will be listed. You'll just click through them, view the webinar, or view the micro lesson, and make sure you take the assessment at the end. There's a short quiz at the end of each of those. Make sure you do go all the way through and complete that to get credit for that micro lesson. So those are up. This chart shows those new micro lessons and ones that are still coming soon, and it links them to the associated webinar that are the topic that they're related to. These webinars are all both on our team's website, but then also on the GaPQC website. So if you go to georgiapqc.org and to our ONN page, you can find all of the recordings for the webinars. So if you missed any of those and you're going to go do the micro lessons, make sure you go catch that webinar as well. And at the end of that webinar, make sure you click through the link to do your attendance for that webinar. At the end of any live webinar, so you're here today live, there'll be a QR code that you'll use to log your attendance. If you're watching this in the future, there'll be a link next to this posting. So just make sure whenever you are viewing a webinar that you do log your attendance. And if you can make sure you're muted and you stay on mute, it'd be great. Thank you. And that's it. Just a couple of updates today. So I'm going to go ahead and hand it to Claire Eden, who's going to give us some updates on MPINC reports.
Yes, hi everyone. Well, as you see, the MPINC reports were released, but starting with the hospital reports in May and the national, regional, and state reports in June. Who has laid eyes on their hospital report? You can raise your hand. There's a little hand raise. I'm looking to see if anyone has seen theirs yet. Or jump in the chat, okay? Hoping to see some hands being raised. We'd love to hear in the chat how you are using your hospital report. Remember, the individual reports are confidential. The data is all aggregated into the state, regional, and national reports. And these reports provide information to help guide your quality improvement efforts, like your work with the Optimizing Newborn Nutrition Initiative. So if you're on this call, chances are you've heard some of us talk about the MPINC and other webinars. We have a whole webinar on the MPINC, and hopefully your hospital participated. Next slide, please. So the MPINC report is the National Survey of Maternity Practices in Infant Nutrition and Care done by the Centers for Disease Control and Prevention. And the survey is to assess maternity care practices and provide feedback to encourage hospitals to make improvements to better support breastfeeding. It's done about every 2 years, and the CDC invites eligible hospitals across the country to complete the MPINC survey. My understanding of what an eligible hospital is does your hospital plan to give, to accept folks who are giving birth, as opposed to like your hospital delivered a baby in the emergency department. So if you have maternity care at your hospital, you are eligible. And it says invites, but in my experience, they do all they can. They contract with a surveying agency who basically beg hospitals to participate. They make many, many attempts to contact somebody at the hospital to complete the survey. And the questions focus on specific parts of maternity care that affect how babies are fed. And then, of course, their advice on how the data is used. Here we are as a state health department and partner to use the MPINC data to work together with partner agencies organizations, policymakers, and health professionals to improve evidence-based maternity care practices and policies at hospitals in our state. But you all that are here as doctors, nurses, hospital administrators, you can use MPINC data to celebrate strengths, and we're going to do that today, as well as improve care practices and policies to better support your birthing patients. So as I mentioned, the CDC sends a report to every participating hospital that shows more specific information about where changes can be made to support breastfeeding mothers. So yes, we have here some information about our participation in Georgia. The MPINC was rehauled in 2018, so it's easiest to compare data over the last 3 surveys. And like I mentioned, they're done every 2 years. So hospitals with maternity services in the US and territories participate. And last summer, when the survey was open, 1,994 out of 2,779 eligible hospitals nationally participated, which is 72%. But you see here that in Georgia, our hospital participation lags behind that quite significantly. We only had a 51% participate last year. Which is down from the previous 2 surveys in 2018 and 2020, where we had 56%. Some trends I noticed here. One is that we have pretty significantly, I guess it's significant to those communities. We have several fewer hospitals that are eligible to participate. In 2018, we had 78 birthing hospitals, and in 2022, they determined we had 75 birthing hospitals in Georgia. And then, of course, we see this drop in percentages. And when we talked through the ways that we can use the data is less reliable for us as a state when we have fewer hospitals participating. So this is my pitch that you'll continue to hear for the next 18 months before the survey opens. Actually, the survey will be open again this time next year. So we expect that it'll be open next summer, spring and summer. So hopefully all of y'all will still be in our webinars hearing our pitch for your hospital to participate in the MPINC survey. Okay, next slide, please. Right, here I've broken down the data a little bit more. The CDC calculates a total MPINC score for every participating hospital to indicate its overall level of maternity care practices and policies. And the total MPINC score is provided in the individual hospital reports. Here we're looking at the national versus the Georgia subscore reports. So there's subscores that further categorize these maternity care practice subdomains. And these here on the left are the subcategories. It's immediate postpartum care, grooming in, feeding practices, feeding education and support, discharge support, and institutional management. On the bottom line, you'll see our overall score. So in 2018, the national overall score was 79%, and the Georgia score was 73. And we've been trending up, as you see across the bottom line. We were up 3 points each year. So, or 2 points in 2020 and 3 points in 2022. Put arrows to show where we stayed the same, where we went up, and where we went down. So luckily in 2022, or not luckily, this is hard work on all of your parts. We were up in every category except for discharge support, which was already pretty high. So we stayed even. We didn't have any losses there. In 2020, we had several areas where we lost some ground. So we went up or stayed flat in all sections from 2020 to 2022. Institutional management and rooming in have been our biggest upticks over the last 5 years, with 10% and 9% increases. And those contributed to our overall increase of about 5 points over the last 5 years or so. So we are helping to bring up the national average in a couple areas. We met the national average for the first time in feeding education and support subscore, and in institutional management subscore. So there's a little playing with the data. Now let's break it down into the individual subcategories. Next slide, please. So in order to identify our areas of opportunity, I broke out, so for each of the subcategories, there are several questions that the hospitals are asked to rate whether they had the ideal response or not. For those of you who are the ones completing the survey, you'll know that it's kind of grouped into, it's clumped into particular, you don't have to answer your exact percent. You answer the question in a range. So for Georgia, in immediate postpartum care, we've talked a lot about skin to skin and the golden hour in this initiative, and we're doing pretty well with vaginal deliveries, the newborn remaining uninterrupted skin to skin contact for at least an hour or until the baby breastfeeds. But in our C-section delivery area, we have a lot of room there. And of course, that's definitely more of a challenge, but it outlines an area of opportunity for our hospitals. We also have room for monitoring newborns for 2 hours continuously after birth, which is an important factor when we are promoting families to room in and to have their baby skin to skin. They need to be monitored to avoid the risk of sudden unexpected infant collapse. Okay, we are on to rooming in, as I mentioned. We've got 3 areas here. One is stands out significantly, which is routine newborn exams, procedures, and care occurring in the mother's room. Only 32% of hospitals in Georgia had the ideal response to this question. We have great rooming in rates at 84%. And we are frequently observing these high-risk mother and dyads. About 63% of hospitals had ideal response there, but routine newborn exams, procedures, and care occurring in the mother's room, we had a big gap here. So we've got our work cut out for that on that, and I'm hoping that we'll use this to guide our work specifically here in the Optimizing Newborn Nutrition initiative. For those of you who have seen improvements or made specific improvements or policies changes in your facility to, you who are among the 32% with the ideal response, I would love if you would share in this chat or contact me or Kimberly after the webinar to share your strategies around how you made that shift. Okay. The next slide is on feeding practices. We are at 75, the national subscore is 81, and this was a big ouch. This was the first place I looked when I opened the report, and I was very sad to see that we dropped back down to 18%. This was our score for this question in 2018, and we had gone up a lot into, I think it was 33% in 2020, and we have backslid completely back down to 18%. So this is the topic of our webinar today. So we'll be talking some more about why so many of our breastfeeding newborns receive infant formula. We're doing pretty well. 89% is a pretty optimal response for not performing routine blood glucose monitoring on newborns that don't have risk factors. And we're hitting a little more than 50% on counseling mothers who request breastfeeding mothers who request infant formula. Okay, discharge support. We, again, are doing pretty decent here. 73% of is our overall score. We are, oh wait, I'm sorry, Kimberly, I skipped feeding education and support. Let's go back to that. Feeding education and support, we are tied with the national subscore, which I think is the highest section for the national subscore too. We're doing pretty well overall with mothers. I guess I've circled our lowest one in each section. So here's one, recognizing and responding to feeding cues, which if you were around for our webinar last month, hopefully you learned some new strategies and a different way of looking at that. If you missed it, please check out the recording on Teams and the GaPQC YouTube channel. And we're also going to have a specific micro lesson on cue feeding for your teams that aren't, necessarily going to be watching all of the webinars, but you want to share some of that information about cue feeding and responsive feeding from the webinar. So you can watch for that this month. Feeding education. Okay, discharge support. We had, we're pretty close in both at 50 to each other and being lagging in discharge criteria requiring direct observation of at least one effective feeding within 8 hours of discharge, and not giving mothers gifts and free samples that are from formula companies. So we kind of a subsection that we could do really well in if we improved on that direct observation of feedings and not undermining our breastfeeding families by providing free samples and coupons. You'll notice that it mentions nipple shields, and as a lactation consultant, I feel like we're probably overly reliant on nipple shields in Georgia, but it's my understanding that issuing a nipple shield for like an indicated reason is not included in this section. This section, I believe, is just like handing things out as gifts or samples. But that's something I intend to look into a little bit further. Okay. And then our last area to look at our areas of opportunity is institutional management. And we have a big, obvious gaping hole in our hospitals having 100% of written policy elements. What's interesting is this also kind of overlaps with the levels of care for those of you with NICUs that are pursuing the certification of your NICU level, your neonatal level of care. You'll need to have a written breastfeeding policy for that too. And that's something we can definitely provide some resources on. The policies that are required, that are outlined, and we can provide resources about how to include those in being drafted in your policy. This is a pretty impactful process for your hospital to undertake as part of this initiative. I am betting, without having requested the data, that the 30% of hospitals with the ideal response here probably overlap fairly closely with our baby-friendly designated hospitals, because that has pretty clear outline that matches up pretty well to these requirements for what policy elements need to be included. Okay, and then the last thing on the MPINC is kind of introducing us over to our topic for today on supplementation and exclusivity. Here you'll see how the CDC asks hospitals to report on formula feeding of breastfed infants. Also, the performing routine blood glucose monitoring of infants not at risk, and then how mothers who indicated breastfeeding as their feeding preference are canceled. So this is just an example of how the scores line up. But for formula feeding of breastfed infants, the hospitals are asked to kind of estimate what percentage of term breastfed newborns receive infant formula. Before we kind of transfer from the MPINC over to the rest of our presentation, I'm just checking the chat. So Eva at Emory University Hospital Midtown says they haven't seen it yet. So look for the person who completed it should have been the one who received the hospital report. So find out, you might need to look for it. And I can put in the chat later the email, do your best to try to find who it might have gone to. But I will, there's an email address that I can find and put in the chat about how to request it. And you'd have to send that email from your hospital email account. And yes, Dr. Patel, I am hopeful that some of these improvements are in part due to our efforts. The surveys were completed last spring and summer, so I'm hoping that we'll see even more improvement when they take the survey, then the report that we get in 2 years. And Emily, I will follow up with you about nipple shields. Great. And so if you were the person who submitted and you didn't receive it, I would be happy. You can send me an email right now to remind me. I'll put my email and I'll send you the email, forward you the information on how to request your report if I can't get to it during the presentation. Here's my email address. Okay. So now let's move on to discussing why exclusive breastfeeding is important, why it's something we want to change our policies to optimize. I know I'm a lactation consultant. I know not everyone can or chooses to exclusively breastfeed. But we also want to center informed consent, informed decision-making around infant feeding choices and optimizing newborn nutrition. So the way I kind of picture this is for folks who want to or intend to exclusively breastfeed, how can we get out of their way as a hospital and as a health care system? And also, how can we safely identify and support families for whom exclusive breastfeeding may not be possible? So in their recently updated AAP statement on breastfeeding and the use of human milk, the Academy continues to recommend exclusive breastfeeding for approximately 6 months. This is, of course, because it's associated with fewer respiratory tract infections, diarrhea, otitis media, obesity. Human milk, of course, has a unique composition, which contributes to, that's the quote, contributes to, I would say, really is the foundation of the developing immune system designed to be. And then less than 6 months of exclusive breastfeeding is associated with abnormal microbiota, which continues past that first 6 months. So in the statement, you can find more about this and the importance of exclusive breastfeeding. Breastfeeding for about 6 months is an evidence-based recommendation, but in an individual counseling situation, we can discuss the desires of the family, cultural variations. We can review the importance of exclusive breastfeeding and ensure that mothers and families are fully informed about their decisions, while at the same time engaging in non-judgmental conversations about the family's personal goals for breastfeeding with the mother. So why is it important to examine our policies and practices around supplementing breastfed infants? Important. So for families who desire to exclusively breastfeed, their experience in the hospital can really make or break whether they meet this goal. As you recall from our previous webinars, separation of mother and baby, misuse of swaddling pacifiers, and supplementing, although those are often necessary, they all do interfere with the optimal establishment of lactation. So first, we need to try to eliminate unnecessary separation, make sure that swaddling, pacifiers, and supplementing are done when in ways that are we can mitigate their effect on optimal establishment of lactation. So with better assessment, and I'll refer back to our lactation risk assessment webinar and remind y'all that we're going to be coming back to that later this year. With better assessment, we can balance safety. I mean, can prioritize safety by optimizing the determination of which dyads need supplementing and preventing scenarios which will necessitate supplementation based on like allopathic reasons. We can also take steps to mitigate the effect of supplementation on the establishment of lactation and the effect on breastfeeding duration. So you might recall this graphic from last month's webinar on Q feeding that demonstrates when concern for milk production kind of can become a self-fulfilling prophecy. But of course, we do have families for which milk production or milk transfer is a legitimate concern for that dyad, and we need to consider their needs as well. Next slide, please. Okay, so how can we improve our exclusivity rate or avoid unnecessarily supplementation? As this as the initiative has progressed, I've had calls from several hospitals saying, okay, hey, now that we're looking at how many of our babies are getting supplemented, we need some strategies on how to reduce our formula supplementation. And in a way, it's an easy answer, but in another way, it's a complicated answer. But the first thing, really, I think, is to look at which babies, and this is, you doing the data collection for this initiative can give you some examples, which babies are getting supplemented, whether you're in the NICU or in Well Baby, and then kind of going down that thread to find out why they were supplemented. So, I mean, in general, instead of focusing on like what to say to somebody who all of a sudden is asking for formula, we want to kind of build confidence throughout the hospitalization through routine feeding assessments, teaching responsive feeding, teaching hand expression, and then this list here where you've got, working on promoting skin to skin care immediately, that golden hour, and afterwards as well. Breastfeeding or expressing milk right away when the baby is born, rooming in, and of course, including those routine procedures that we see we're really falling down on making those happen in the room. So looking at working with your team on what needs to happen to get those routine procedures done at the bedside with the parents. Routinely teaching hand expression and responsive feeding. If your hospital did not have that ideal response to the routine hypoglycemia screening, taking a look at that. The feeding assessments, which we're going to come back to later this year, and we'll also have a micro lesson associated with using the latch score or other standardized feeding assessment. And then operationalizing those lactation risk assessments that we introduced and the interdisciplinary communication that should happen along with those to maximize patient safety. None of us want to be the person who really promoted exclusive breastfeeding for a dyad that turns around and gets readmitted 2 days later. And often we can predict that. And then, of course, including fathers, partners, support people in those teachings and assessments, that can really help facilitate the development of a more conducive environment for the continuation of exclusive breastfeeding after discharge. So that was a lot of talking. All right, from our next slide. So if a family is asking for formula, what happens next? What's your policy? So assuming that this is after the attempts to latch the baby have been unsuccessful, really with no assumption, always the very first step should be active listening to what the mother's concerns are or the partner's concerns if it's a partner asking, and kind of reassessing where we are. If attempting to latch the baby has been unsuccessful and the baby is really frantic, then they'll need to be put skin to skin, sucking on a clean finger or pacifier to calm the baby before attempting to latch again. This is where, of course, to call in your lactation consultant if it's not, if it's a time that you have one available. And I know all of our hospitals pretty much universally are understaffed with lactation consultants. So this might be also a time to identify who the person on your shift who is kind of the champion with helping with latch, positioning and latch could come and help. Another strategy is to demonstrate hand expression if that hasn't happened already. review that demonstration and to spoon or syringe feed the colostrum that is yielded from the hand expression right away, and talk about how it's helping the baby's immune system and how it's, it's very nutrient dense, and do the teaching along with the intervention. Teaching how supplementing, reminding or doing that teaching about how supplemental feedings can interfere with the establishment of milk production should be part of the decision-making process, because if the baby does need to be supplemented, then we would need to introduce hand expression along with the supplement in order to mitigate the risk to optimal establishment of lactation. And then, of course, document and do what you can to get back on the horse. If we've decided, next slide, please. If we've decided that we do need to supplement for medical reasons, then of course hand expression is your first line of defense. If the indication is hypoglycemia, if your hospital doesn't already use glucose gel, it's something to consider. More and more hospitals are implementing the use of pasteurized donor human milk or shelf-stable human milk products to supplement term infants for whom medical supplementation is indicated, or parents request for breastfed infants. Teaching paced bottle feeding, we're about to get that loaded up. We're bumping into some technical issues with multiple videos happening in our micro lessons. We're going to get that loaded soon on how to teach paced bottle feeding. This is important really for all families who are not exclusively breastfeeding, from families who are exclusively feeding express milk all the way to families who are exclusively feeding formula should be taught paced bottle feeding. But especially including those for whom supplementation is medically indicated for more than just one, a couple syringes of colostrum. Safe discharge planning is important and should include referral for lactation support and follow-up. It's important to know who in your community is available for referrals. If your hospital doesn't offer outpatient lactation support, and if your hospital does offer outpatient lactation support, making sure families have good information about how that works, how reports will get to their pediatrician, how you collaborate with other folks in the community so that we can really, when referrals are made to WIC for peer support, things like that. We're going to talk next month more about physiologic volumes, but when supplementation is indicated, it's really not ideal to just hand a new parent a 6-pack of ready-to-feed formula and some standard flow nipples, because they won't know how much to feed, how to pace the feeding, what kind of volume is physiologically normal for a baby who's 6 hours old, 12 hours old, 30 hours old. So make sure you have a policy about that, and that there is a plan. Flip side of that is that there is a plan to increase those volumes if the baby continues not to feed well. Alternate feeding methods should be considered if it's in the first 48 hours or so, and the supplementation is likely to be short term. If you have a dyad where there's a lot of lactation risk factors, and we know that supplementing is going to need to happen until they are outpatient and have good lactation support and assessment with the pediatrician office as well, then discharging them only syringe feeding can be a real disservice, because they may continue to underfeed if the baby isn't transferring anything at the breast, or there isn't anything at the breast to transfer of significance once we get out to 72 hours, 4 or 5 days old. So those are some the strategies to consider when the decision to supplement has been made. So lastly, I wanted to kind of review, and we're going to have some discussion. I see some things are coming through the chat afterwards, but ways to mitigate the risks of supplemental feeding to breastfeeding duration and exclusivity. Of course, the reason that we're supplementing in often cases is to mitigate risk of underfeeding, of course, but they're also the flip side of that we're we're measuring or weighing against is the risk to breastfeeding exclusivity and duration. So first of all, having a clear plan about the supplement and communicating it is important to individualize the care. As a lactation consultant, outpatient or in the NICU, I hear from families to say like, oh, I started out breastfeeding, but the baby needed to be supplemented. And basically that meant all of a sudden now the baby was only formula feeding instead of the supplementation being specific to the situation scenario and with a clear plan on when the parents should stop supplementing, or how they would wean off the supplement, how they would know it was okay, safe to wean off the supplement. And some of that, to be fair, is going to have to happen right with the outpatient primary care provider. Using donor milk if available, there's some interesting studies about how the use of donor milk to supplement term healthy babies outside of, our typical kind of NICU scenario can increase breastfeeding duration and exclusivity. Of course, donor milk means from a PCO5 state, you can say they were exclusively breast milk fed. So it helps the stats there for Joint Commission for those of you who are subject to Joint Commission. But in terms of actual breastfeeding exclusivity at the breast, the mother's breast or mother's milk exclusivity, there's a case to be made that using donor milk can kind of risk the parents' choice and reinforce the value of exclusive breastfeeding. So it's something to consider. And I know some of y'all who are doing it are here on the call, so we might have some opportunity to talk about what that shift has meant in your exclusivity rates and your family's success rates in meeting their feeding goals. As I mentioned, feeding physiologic volumes. If it's the first 24, 48 hours, they don't need 50 mLs of ready to feed formula. And in fact, overfeeding that much can mean that the next feed and the next feed and the next feed get delayed, which means even less stimulation to the mother's breasts. Teaching paced bottle feeding, assisting families with skin to skin, supporting the mother to express milk in association with each supplemental feeding can help match up that stimulation to her body to what the baby is needing. And then, as I mentioned, appropriate discharge planning and lactation referrals. So I'm sure some of you have other ideas on ways to mitigate the risk of supplemental feeding to breastfeeding duration and exclusivity. So I'm going to take a minute now to go back and look at the chat and see if we've got, let me get to the chat, if we've got any feedback from the group on either strategies to communicate with families about their decision to supplement or our decision that they need to be supplemented. And then other strategies for mitigating the risks of supplementing. So Dr. Paez is asking that we discuss the recommendations to decrease excessive glucose checks of babies whose mothers have a diagnosis of DM type 2 or gestational. Okay, so for those of you, I know there's some peds on the call and hospitalists. If you have input for Dr. Paez, I was discussing specifically not doing routine screening for babies who are not at risk. Strategies to improve education in terms of having the baby adjust. And also, while I'm thinking about it, make sure that if you have questions around this, that you have watched our EPIC breastfeeding education webinar from a couple months ago on hypoglycemia. This is not, not everyone agrees on how to manage this. So there's some good resources based on the Academy of Breastfeeding Medicine protocol in our recent EPIC breastfeeding program. Is there anybody on the call, any peds who want to speak up about that? Here's the website to find our on-demand library. It's free. Anyone? Bueller? My recollection from our EPIC program was that there is a transition period for babies. And I think that's what you were calling out, Dr. Pius. So if you have more to share, feel free to unmute or jump on the chat about that. Anyone else? I tried to be as thorough as I could, but I don't have a lot of lived experience working in a birthing facility on this. So I was hoping to hear from some of you about ways or mitigation tactics or strategies that have been successful for you. For those of you who are using donor milk particularly, I'm interested to hear if you feel like that has changed how things work in your unit around supplementation. All right, well, we're a quiet group today. As I mentioned, we're going to have some micro lessons that will work together well with, it's funny because every time I try to match up micro lessons to webinars, like they all go to multiple different ones. So we'll be having, dropping in June, our safe milk collection and storage, infant feeding cues, PACE bottle feeding, and antenatal milk expression, which I know is a really hot topic right now, and a lot of hospitals are trying to figure out how to manage that. And then coming in July, we will have safe sleep and breastfeeding using the newborn weight tool for in the first 24 to 36 hours, and your top 5 prenatal breastfeeding education topics. Oh, I hear going live with donor milk in the mother baby unit tomorrow. Oh, I'm very interested to hear, Aubrey, how it goes. That's exciting to hear. Well, if we don't have much more to discuss, I will also pitch. I gave a pitch on our on-demand library for EPIC, but coming up in June 29th, in a couple weeks, we're going to have a panel of pediatricians and an OBGYN speaking on nursing and weaning the older baby and toddler. So sort of the other end of the breastfeeding spectrum from where we are today. But we are going to have our own Dr. Pius, who's here on the call today, as part of a panel with Dr. Hallens, who's an OBGYN, Brandy Giesling, Amir Babrov, moderated by Haral Lavanya, who is one of our breastfeeding friendly certified pediatricians here in Georgia. And it'll be a good way to reflect on the AAP's new recommendation for duration of breastfeeding for 24 months or longer, and kind of balancing that, as I mentioned, kind of in the beginning of this presentation today, about how to support that without feeling pressuring or haranguing folks that they have to breastfeed for longer than they're ready to, but perspectives on how that looks, what it looks like for us as healthcare providers to shift some of our phrasing, and to build our fund of knowledge on how to answer questions around nursing and weaning an older baby and toddler, and also what it looks like weaning off pumping at work, things like that. So we've got a great presentation. You can register at gaepic.org as well. I think if this picture this picture doesn't have the QR code on it. I apologize. But you can always register by going to gaepic.org. It's free. We provide CME if you attend live. It's about an hour over lunch on Thursday, June 29th.
Awesome, Claire. Thank you so much for today. I do have a couple of dates reminders. June 26th, that June audit will be out. So data leads, look for that Monday morning. And then July 11th will be our July webinar. And we look forward to seeing you all there. And make sure you scan this QR code to log your attendance for today's webinar. See you all next month. Thank you so much.